Good morning. Good morning. Good morning. Good morning.
So yeah, it is. All right. I feel much better about now. All right. Okay. Okay. Well, I did a video. That's what I did. Yeah. It doesn't matter how long. Like, that's how I don't know if I did it well. Not that weird.
Okay, gang, it's time to get started. So, I don't know what on earth is wrong with this bloody thing, but it just keeps going out all of a sudden. And it's really annoying. All right, we're talking about asthma. We're a little thin on the ground today because our baseball team is out and our softball team is out. The notes on page 98, there's a summary of asthma classifications. That will become very important when we talk about treatment. So make sure that is close at hand. Then on the next few pages, there are a list of different asthma and not just asthma, but also medications for allergic rhinitis, since there's antihistamines on there as well. and various other types of drugs. So that goes from page 99 to page 101. Page 99 to page 101. All right. Let's start with a word of prayer. Father, thank you for warmer weather. We are getting into the home stretch of this semester. For some, the home stretch of their actual college careers. Help us all to finish strongly, whatever year we might be finishing. Thank you for every student here, whether online or in person, for all their hard work. Lord, reward them commensurate with that hard work. In Jesus' name we pray. Amen. So we looked at this drug that's used to prevent asthma. This drug cannot be used to stop an outbreak of asthma. It's only used to prevent asthma. So we looked at how immunoglobulin E binds to mast cells when immunoglobulin E is cross-linked by allergens that causes the mast cell to dump its granules. So an antibody against immunoglobulin E called omalizumab will bind to serum IgE, prevent it from binding to mast cells. That will prevent allergy outbreaks. This drug is given subcutaneously. Unfortunately, you have to go into the doctor's office to get a dose. There is a self-injector that is in the process of being approved by the FDA, which means that none of us has any idea when it'll get approved. This drug, unfortunately, is quite expensive. And those other two drugs up there, chromal and sodium and natochromol, those are inhaled. So you give those by dry powdered inhaler, DPI. These are cheap. They're only, again, preventative, but these are drugs that stabilize mast cells. They prevent mast cells from dumping their granules. And chromal and sodium is the one that's used the most. If you see reports online that chromal and sodium causes cancer, do not believe them. Those reports have been widely discredited, even though you'll still see them. And sometimes it's amazing the half-life that myths have online. It really is. I'm still seeing stuff online that saccharin causes cancer. That old saw comes from the 1980s. And it's been disproved now for two decades, yet you still see it. We could make a spiritual analogy here with heresy, I suppose, but I won't go that far. I'm so done with masks. I'll continue to wear them because it's the rules, but I'm so done with them. All right. So omalizumab, when you take out circulating IgE, you also prevent proliferation of eosinophils. And eosinophils can play a big role in asthma. So these do more than just take out IgE. They have these kind of downstream effects that you see here, where the eosinophils, their numbers go way down. And again, this drug is safe during pregnancy and lactation, and it's safe for children as well. And then these are the mast cell stabilizers. Chromal and sodium is the one that's definitely used the most. Natochromol, not quite as much. And these don't work all that well. If you use these, you really need to combine them with another treatment. Other preventatives include these three biologics. These target interleukin-5. So these are specific for asthma characterized by very high eosinophil counts. That type of asthma tends to be very resistant to treatment by other means. So they often fail other treatments. So these agents target interleukin-5. Interleukin-5 is very important for the survival and proliferation of eosinophils. One of these attacks the interleukin-5 receptor, that's benralizumab, and the other two bind to circulating interleukin-5, prevent it from binding to its receptor, that's reslizumab and mepolizumab. Mepolizumab comes as an injector, self-injector. You inject the medicine subcutaneously yourself, and then reslizumab is given intravenously. You have to go into the doctor's office to get reslizumab, not as convenient. So this next picture shows you how they work. So reslizumab, mepolizumab, they bind to circulating interleukin-5. Benralizumab takes out the interleukin-5 receptor, prevents it from binding its interleukin-5 ligand. These medicines are all very effective. And from the research that has been done on them, both post-marketing and in their phase 3 trials, they tend to be rather well tolerated. They can increase your risk of other upper respiratory infections. To some extent, they can also cause you to have dry mouth and so on and so forth. Other than that, they're pretty well tolerated. These medicines are kind of new, and unfortunately, they're wildly expensive. You start out taking them every month, then you take them every 2 months. After you've taken them every month for a couple of months. Dupilumab is also a new drug. This is also injected subcutaneously. This inhibits also a monoclonal antibody. See the MAB at the end? That means it's a monoclonal antibody. This attacks a common subunit that is common to the interleukin-4 and interleukin-13 cytokine receptors. So this is an anti-cytokine receptor antibody, and it binds to that common receptor. Therefore, it takes out signaling from interleukin-4 and interleukin-13. Interleukin-4, you will remember, maybe, will induce B cells to undergo isotype switching to make immunoglobulin E. Interleukin-13 is a cytokine that will induce the proliferation and hypertrophy of smooth muscle in the airways. So that signaling is very pro-remodeling. This particular medication prevents remodeling by preventing signaling by interleukin-4 and interleukin-13. Now, the FDA has also approved this medication for atopic dermatitis that is quite refractory. Do you guys know what atopic dermatitis is? No? So atopic dermatitis refers to the rash you get from allergies. Some people with allergies get very, very bad cases of hives and rashes and things like that. Some people have rashes and hives that essentially afflict them no matter what they do. And so if you essentially have this type of situation, you can get approved for dupilumab, and it will usually take those hives right out of your life, and you will have a new lease on life. So that's dupilumab, both for chronic asthma and for atopic dermatitis. Severe refractory atopic dermatitis. And this just shows you the cartoon of how this antibody works. You can see this it's an anti-interleukin 4 alpha receptor subunit antibody. That subunit is used both as the interleukin 4 receptor and as the interleukin 13 receptor. So this binds to that common subunit and prevents both of them from working. And the Liberty trials were the clinical trials that showed that dupilumab in patients age 12 and older had decreased asthma events, had decreased serum IgE. That's no surprise, given that you're inhibiting interleukin 4 signaling. That decreased blood eosinophil counts, increased lung function, decreased dependence on oral corticosteroids, reduced marker of inflammation, and was well tolerated. You had reactions at the injection site. You had headaches in some people. There's a very low percentage of people who had bad GI distress. That was very rare. And then an increased risk of upper respiratory infections. Beyond that, the medication was quite well tolerated. If you have allergic rhinitis, antihistamines are a very good drug to use because they bind and inhibit the H1 histamine receptor. Now, histamine is also a neurotransmitter in your central nervous system. In fact, histamine is important for alertness. And first generation antihistamines are very lipophilic and they cross the blood-brain barrier. And they inhibit the H1 receptor in the central nervous system. Therefore, they tend to cause drowsiness. In some cases, they can cause extreme drowsiness. So these drugs here, I'm sure all of you have heard of Benadryl. So that is the trade name of diphenhydramine. Diphenhydramine. This is a very common, popularly used drug. And it's also used in medicine for several things. For example, some antipsychotics cause a movement disorder called tardive dyskinesia. Diphenhydramine is used to treat tardive dyskinesia in schizophrenic patients on antipsychotics who get these movement tics and things like that. Did any of you see the movie Awakenings with Robin Williams? It's an old movie now. It's about a doctor. Robin Williams plays a doctor who gives people who have this neurological condition, because it's a sequela of a severe viral infection. They're essentially in kind of a catatonic state. But he notices that if he throws a tennis ball at them, they'll all of a sudden catch a tennis ball. And so that's his assay to separate people who can be treated with this medication if they can catch the tennis ball. So there's a scene of him throwing tennis balls at people, and some of these people, the tennis ball hits them in the face, and all of a sudden the patient, the tennis ball is coming at them and they catch the tennis ball. So he gives them these very, very high dosages of L-Dopa, and that's a Parkinson's drug. And they all of them come out of this catatonic state and they live normal lives, at least for a brief period of time. And there's scenes of them, they go dancing and they get to go to a shopping mall for the first time in decades, and they get to buy new clothes. And it's just, frankly, very emotional set of scenes for these people who are in wheelchairs this whole time, basically being fed by somebody else. All of a sudden can live these normal lives, and then they start having these movement issues, these tics. They start, doing stuff like this, and it's a side effect of the L-Dopa. And they didn't know back then if they treated these people with diphenhydramine, that might have stopped and they might have still been able to live these normal lives, but you have to take them off the medication, and then very slowly they all go back to being in wheel. That's why the movie's called Awakening. It's a very, very good movie, very different role. Robin Williams for the movies that he's normally known for. But that's the use of diphenhydramine that could have been used for. Now, the second generation antihistamines do not cross the blood-brain barrier. They do not cause drowsiness, except at very high concentrations in some cases. So cetirizine, for example, which goes by the trade name Zyrtec, at high concentrations, that drug will cause drowsiness. At normal dosages, it does not cause drowsiness. Fexofenadine is virtually impossible to OD on fexofenadine. That drug, you could take several grams of it a day without side effects. It's very, 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 very safe drug. So if you have allergies, don't take the first generation drugs. You fall asleep. Also, don't take diphenhydramine to go to sleep. Many people do that if they can't sleep. Don't do that, because these drugs have anticholinergic effects as well. REM sleep requires acetylcholine, so they actually disrupt REM sleep. So yes, you'll fall asleep faster, but your quality of sleep will be worse. There are other drugs that are better to fall asleep. Don't take diphenhydramine. Bad idea. Bad idea. So second generation, that's your way to go, essentially. Also, in older patients, first generation diphenhydramine, first generation antihistamine can cause falls. So that's another feature as well. Also, because they have anticholinergic effects, they can cause things like bladder retention, urinary retention of the bladder, and other types of effects as well. If you have a psychiatric condition, it can make it worse. So these drugs should just not be used in elderly patients at all. Theophylline is a drug that is used for emergencies. So this drug is a very powerful bronchodilator. We saw how it worked. It's a phosphodiesterase inhibitor. So cyclic AMP levels are now increased, and cyclic AMP has a much higher half-life in those smooth muscle cells. That causes them to relax. You bronchodilate. So it's used for emergencies. Problem with this drug is it causes tachycardia and has a very narrow therapeutic window. So this is your go-to for emergencies. You don't use this drug long-term in children because it'll cause learning defects. Yeah, that are permanent. So it's not to be used in children long-term. It can be used in children for emergencies, but not long-term. If you have an asthmatic emergency, the drug and only drug of choice is epinephrine that comes in an injector pen. You take the injector pen out and you put it into a nice big muscle. Usually, the most easily acceptable big muscle is a quadricep. So you take it and you jam it in the leg and you dispense the medication. You must do this without queasiness or fear. And if someone is passing out and they have an EpiPen, you take it out and you jam it in the leg. Doesn't matter if they're a kid, doesn't matter if whoever they are, that's how you do it. Now, to do this, people sometimes need practice. So drug companies make practice injector pens. You take this off to prime it and you jam it in the leg, and then if you want to practice again, you just recock it, and that's essentially how you do it. And so for my nursing students, if they don't wake up, I will go by and I will usually say, wake up. I'll give them their shot of epinephrine, and that should be better than coffee, but some of them still fall asleep. Anyway, probably because I'm so bloody boring. So these are free. If you get epinephrine, you usually get one of these, and they're a great toy. Essentially, nice thought toy. You can sit there and, oh, let's see, how does that work? Just kind of shoot yourself up with epinephrine all day, better than coffee, and no side effects. You might get bruising, but this essentially is a nice demonstration of how to use an EpiPen. It's very clear EpiPens are underused. And they are, again, some people say, oh, they can't breathe. Give them Benadryl. No, 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 no. Slap yourself. No, not Benadryl. Epinephrine. Benadryl takes way too long to work. This works right away. So use epinephrine. That's the only drug. Everybody say that with me. Epinephrine is the only drug. You don't believe it. Come on, believe it. Epinephrine is the only drug for asthmatic emergencies. Only drug. So if someone has asthmatic emergencies, and if they have one, they should carry a medical alert bracelet. And we had a student now who's in graduate school, Ashley Bartlett, who went into Whiteman Gibbs to listen to a seminar. She was massively allergic to someone's perfume. She walked out of the room, walked into Whiteman Gibbs' office, and passed out. And they called, well, they, being Mrs. Schaefer, called the ambulance, and they gave her epinephrine. And they said, why in the name of creation don't you have an EpiPen? And she just had to say, because my doctor's an idiot. And that was a fact. So she switched doctors and promptly got an EpiPen. So again, it's clear from lots of research, these are underprescribed and underused. So EpiPens are the only drug for an asthmatic emergency. If I ask you that on a test, you're going to say epinephrine, right? If you don't, you should fail. You have only yourself to blame. Epinephrine. Now, if it's not an emergency, but you're wheezing, what do you use? You use a beta-2 agonist. A beta-2 agonist. Those bind the beta-2 receptors and they promote broncho relaxation, bronchodilation. These are so-called rescue treatments. Rescue treatments. Now there are short-acting beta agonists, SABAs, short-acting beta agonists. Some of you may know people who have these. The inhaler will have a cap, and that cap is usually a red color. Does anyone have one? Just to ask. In a room this size, normally there might be one. Do you have it with you? No? Can you bring it with you next time for show and tell? Yeah, make a note to bring it with you so you can show everybody. So that's for exercise-induced asthma. That's for other types of triggered asthma. That's your rescue inhaler. You get very quick relief with that. Now, there are also long-acting beta-2 agonists. Long-acting beta-2 agonists are never used as a monotherapy. They were at one time, not anymore. They're used with steroids. So long-acting beta agonists are used for long-term control. Short-acting beta agonists are used to relieve symptoms. Neither one of these drugs affects inflammation. And since inflammation is a hallmark of asthma, these drugs just relieve symptoms. They don't hit inflammation. They just relieve symptoms. They don't affect inflammation. Epinephrine doesn't affect inflammation either, but it'll help you breathe. So these drugs look chemically like epinephrine. They bind that beta-2 receptor and they activate it, causing bronchodilation. Now, the smooth muscle of the airways is also innervated by vagus nerve termini. Vagus nerves release acetylcholine. So you can also use drugs that block muscarinic receptors. Those will also promote vasodilation. Sorry, bronchodilation. And these are your inhaled antimuscarinics. Your inhaled antimuscarinics. So a short-acting antimuscarinic, or a SAMA, can promote bronchodilation. Then you have a long-acting antimuscarinic, or a LAMA. That's for long-term control. Again, these do not affect inflammation. They're just used to relieve symptoms. Antimuscarinics are not first line for asthma. They're usually second, third line, but they are first line for chronic obstructive pulmonary disease. So again, not first line for asthma, but first line for chronic obstructive pulmonary disease. That essentially is emphysema. Emphysema. So on your left-hand side, you have a SAMA, short-acting antimuscarinic, hypertropia. Short-acting, lasts 4 to 6 hours. Just relieve symptoms. And then on your right-hand side, you have teiotropia. That's a llama, not the animal. Long-acting antimuscarinic. That has a duration of about a day. Again, not first line for asthma, although they can be part of an asthma regimen, but they are first line for chronic obstructive pulmonary disease, otherwise known as COPD. Now, for long-term control of asthma, first line are your inhaled corticosteroids. Inhaled corticosteroids. You never use inhaled corticosteroids as a rescue treatment. Why? Because they take too long to work. Inhaled corticosteroids are for control. So inhaled corticosteroids at low dosages are very well tolerated. If that low dose doesn't work, you bump up the dose. And if even a high dose inhaled corticosteroid doesn't work, then you go to an oral steroid. You don't want to ever use oral steroids long term. They have too many side effects. But if it's that, or your patient suffocates to death, then you do it. You're just getting them back to normal while you find some other treatment, like a biologic or something like that. So here are just some of the structures of these steroids. The drug out of these that gets used the most is almost certainly this one up here, fluticasone. These others all have their uses. Dexamethasone is not used as an inhaled steroid. That is a systemic steroid. That's an oral systemic steroid. The other two are prednisone and methylprednisone. I'm betting you guys have heard of prednisone. It's a very widely used drug. Systemic oral steroids. And here are the structures of these two oral systemic steroids, prednisone and methylprednisone. The methyl group right here is your methylprednisone. Methylprednisone goes by the trade name sometimes Medrol. Prednisone has been around so long it's in generic, has been for years. Pretty cheap drug, very powerful anti-inflammatory with a whole potload of side effects. Let's talk about some of the side effects of systemic steroids. This is a long list. You'll see why you only use these short term. So first, there are cardiovascular side effects. One, hypertension. If you have a susceptible patient, it can also cause heart failure. These cross the blood-brain barrier, so they have central nervous system effects too. So emotional lability. Translated, that means mood swings. Headache. Increased intracranial pressure. Psychiatric disturbances, which can take lots of different forms. Seizures, vertigo, you can also have atrophy of the skin. The skin can thin out. You can get rashes. You can have diaphoresis. That means intense sweating. You can have decreased serum potassium, increased blood glucose levels, and an increased risk of the onset of diabetes. Fluid retention. Hypothyroidism. If you're a female, you can have menstrual irregularities. You can have a decrease in protein synthesis and an increase in protein degradation. Pancreatitis. Ulcerative esophagitis. Increased risk of infection. Decreased bone density. Osteoporosis. Increased pressure in the eye. Increased risk of glaucoma. Decreased wound healing. That's a short list. Should I go on? No, I won't. You see why you only use these short term? Can you imagine the headache that the nurses have trying to track all those side effects? You usually use it for about 2 weeks. That's how long you use it. Some people can be on low doses for a very long time. Once you get up to the high doses that are usually needed for severe asthma, you're looking at side effects, severe side effects. Now, the leukotrienes, again, mediate the long-term effects of asthma. There are also drugs that can inhibit the effects of leukotrienes. So these bind to specific leukotriene receptors. There are drugs that block those receptors. These are your anti-leukotriene drugs. They block the leukotriene receptor, and the main drug in the US is montelukast. That drug goes by the trade name Singulair. Zafirlukast is available in Europe. It's not available in the US because people who take it were more prone to liver damage. So that drug is not available in the US. Xyluton works differently. It prevents the synthesis of leukotrienes. It inhibits the 5-lipoxygenase enzyme that's used to make the leukotrienes. Xyluton is available in the US. It's not used that much, but it is available. And this has unfortunately been linked to some cases of drug-induced liver disease. Those are rare, but they do exist for that reason. It's just not used that much. So in the synthesis of leukotrienes, the vital step is right here, where you go from the 5-HP to the leukotriene A4. That's your 5-lipoxygenase. That's inhibited by xyluton. And then montelukast, zafirlukast, they prevent these leukotrienes from binding to the receptors. And then your glucocorticoids actually inhibit the phospholipase A2 that liberates arachidonic acid from the membrane lipids. And then NSAIDs, of course, inhibit cyclooxygenase. That inhibits this part here, the synthesis of prostaglandins. But this whole thing essentially is cut off at the knees by the glucocorticoids. That's the structure of the anti-leukotrienes. Again, they're not used as a rescue treatment. They're used for long-term control. They're not first line. If they're used, they're usually layered onto other drugs. Okie dokie. Let's now take a look at the clinical use of these drugs. So, question one that you ask, if someone is having respiratory symptoms, are their symptoms consistent with asthma? And the symptoms of asthma, very simply, you have dyspnea, that is, you have labored breathing, shortness of breath. With asthma, it's going to have a trigger. That's one of the first things you need to know about asthma. That trigger will cause asthma to come on. The asthma will usually have an attack. It'll peak, it'll decrease, and then there'll be rest between that asthma attack. If you have a constant sort of dyspnea, it's probably not asthma. That's why you need to do a very detailed medical history and examination first. So that's one of the first things you do. If you have consistency with asthma, then you start treatment. And you need to do spirometry with reversibility. This is a hallmark of asthma. It's reversible. It's reversible. So one of the tests that you do usually is something called a metacholine challenge. A metacholine challenge. Metacholine is a bronchoconstrictor. If they show constriction with metacholine, they don't have asthma, that constriction will not cause them to go into an asthma attack. Asthmatics, however, have bronchial tubes that are more irritable. And a metacholine challenge will almost always cause them to have an asthma attack. Then that should be reversible by giving them a beta-2 agonist. So you induce it, then you reverse it. If that happens, they have asthma. They have asthma. And that will confirm your diagnosis. So the typical respiratory symptoms are wheezing. When they breathe, you can hear that railing sound. That's the wheezing. If you never wheezed before, just find someone who is wheezing. You can't miss it. You just can't miss it. You don't even need a stethoscope to hear it. You can hear it as they breathe. Tightness in the chest, cough, shortness of breath. People with asthma will have one or more of these symptoms typically. The symptoms will vary over time. They also vary in intensity. Again, triggers. Symptoms are worse at night or upon waking. Worse at night or upon waking. They're triggered by exercise. They're triggered by laughter. They're triggered by cold air. They're triggered by allergens. Triggered by stress. Triggered by somebody's perfume. Triggered by foods. Triggered by fill in the blank. Trigger. Asthma has a trigger. So it's inducible. And the symptoms will usually worsen or get worse with viral infections. Put a little star by that one. That one's really important. Corinne, what do you have there? What is that? Oh, you have to measure them. Okay. Now, is there a way you can put numbers to their respiratory function? The answer is yes. You do something called spirometry. And this is a domain of the respiratory technician. So you do a test called an FEV1, forced expiratory volume 1. You're asking how much air can they exhale in 1 second if they give it all they got. And then you're going to divide that by their total forced volume capacity. And if you measure that, most of the air that comes out should be about 75 to 80% in adults. It'll be about 90% in children. In asthmatics, the variation of lung function is a lot greater than it is in healthy people. And this wild variation in this ratio, that's indicative of asthma. And also, if that ratio is low, you can reverse it with a dose of a short-acting beta-2 agonist. That's not the case. The condition is not asthma. It's something else. So your goals for treatment. You want to achieve and maintain control of symptoms and prevent exacerbations, prevent these outbreaks. You want to maintain pulmonary function, maintain normal activity levels, make sure they can do the things that they want to do. If you like running, but you can't run because every time you run, you can't breathe, you should be able to get to the point where you can run. If you like biking, you should be able to bike. If you like playing polo, you should be able to play polo or what have you. If you like your pets, you should be able to hang around your pets and not have asthma outbreaks or whatever. You want to avoid adverse reactions from medications. So you always start with the lowest dose and then go up. You want to prevent development of irreversible airway obstruction. You're trying to prevent this remodeling of the airways that occurs during chronic asthma. And you want to prevent asthma mortality. Those are your goals. Those are your goals with treatment. So you review your diagnosis, symptom control, risk factors, inhaler technique and adherence, patient preference. You assess that. Then you see how the patient is doing and you adjust the treatment as needed. You also tell them to stay away from their triggers. So you talk about behavioral strategies, things like that. Then you review the response and you keep this cycle going while you are in consultation with your patient, constantly reviewing, constantly tweaking, trying to make sure that your patient has their normal activity levels, can do the things they love to do, and have a reduced number of asthma attacks. Now, this is a treatment algorithm. This is a treatment algorithm. And this is based on your classification of asthma. So if you could please get this out on page 98 so we can look at it. So mild intermittent asthma, cough, wheeze, blah, 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 so on and so forth, less than twice a week. Flare-ups are brief, intensity varies. Nighttime symptoms less than twice a month. Lung function is essentially normal. Peak flow rate less than 20% variability. This person's lung function is largely normal, but when they get these flare-ups, they're bad. So that is mild intermittent asthma. This person needs a rescue inhaler. They don't have a lot of inflammation in their lungs. They don't need a steroid yet. So they are treated with a short-acting beta agonist. That's all they really need. That is mild intermittent asthma. Next one. Symptoms of asthma 3 to 6 times a week. So now, at the worst, it's almost every day. Flare-ups affect activity levels. Nighttime symptoms 3 to 4 times a month. So nighttime symptoms once a week. Peak flow is above 80. Peak flow, lung function, sorry. Peak flow less than 20 to 30% variability. Now that variability is getting higher. Now they're put on a low dose steroid. They take that once a day on top of their rescue inhaler. They use a rescue inhaler when they have an outbreak. That is to quell the symptoms of the outbreak. The low dose inhaled corticosteroid is to make sure that the asthma is controlled, so they have fewer outbreaks. Now, if that doesn't work, then you step up to medium dose inhaled corticosteroid on top of the, again, you're layering drugs on each one of these. So you bump up your concentration, or to the low dose inhaled corticosteroid, you add a long-acting beta agonist. If you add the long-acting beta agonist on top of the inhaled corticosteroid, that gives you added control. And then you have the rescue inhaler. The alternative would be to use singular, to use montelukast, if they don't tolerate steroids, if they don't want to use an inhaler, because those drugs are oral. Next one is moderate persistent asthma. Now they have daily symptoms. Flare-ups affect activity levels. Nighttime symptoms more than once a week. Peak function is between 60 to 80 of normal. Now you're outside the normal range. Peak flow is more than 30% variability. So the variability from day to night, mid, pretty variable. So now you're going to essentially go into this range here. So what do you add on top of this? You bump up the dose plus the long-acting beta agonist in addition to the rescue inhaler. Alternatively, you keep the medium dose and you add singular or something like that. Or if it gets really bad, then you go high dose. Inhaled corticosteroid plus the long-acting beta agonist plus the rescue inhaler. And those who have an allergic type of asthma with high eosinophil count, consider omalizumab. It's very effective in people for whom the steroids don't work. Severe persistent asthma. Now you have several outbreaks a day usually. Nighttime symptoms frequently, over 5 times a month. You're having them several times a week sometimes. Big flow, more than 30% variable, less than 60% in your spirometry. Now you're essentially up here. And now your high dose, you might also consider an oral corticosteroid. You don't keep that oral corticosteroid for long. Now you want to start to consider a biologic. So consider dupilumab, consider benralizumab, consider mepolizumab, reslizumab, something like that. And usually, if not, you should be under the care of an allergist. You should be under the care of an asthma specialist. You bump it up each time. You layer medications, you increase dosages, you layer medicines on top of this. That's how the algorithm goes until you get control. Once you get control, if you want to try to ratchet down the concentration of the drug, you can. You use the lowest dose of the drug that works. Lowest dose of the drug that works. Are there questions on any of this? Now, one other thing to assess with your patient is this. Are they using a meter dose inhaler correctly? Because several studies have shown the majority of people who use a meter dose inhaler don't use it properly. Also, many medical professionals who teach people how to use a meter dose inhaler don't necessarily teach it properly. So, how do you use a meter dose inhaler? Let's take a look at this video that shows you how to use a meter dose inhaler. Okay, so to get sound, I plug this in. And then, okay, that's on. Oh, let's see. Turn you up. Okay, give this a shot.
People who have lung conditions like asthma or COPD often take their medication using a handheld device called a metered dose inhaler, or MDI. A metered dose inhaler sprays medicine through your mouth so that it can reach your airways. If your inhaler is not used the right way, something may not enter your mouth, or some may remain in the back of your mouth. Either way, it may not reach your airways where it is needed. This video will show you the general steps for using an inhaler correctly. It's important to follow the instructions that came with your metered dose inhaler. A metered dose inhaler has three main parts: the mouthpiece cover, the plastic sleeve with the mouthpiece, and the medicine container. Before using your metered dose inhaler, remove the mouthpiece cap and shake the inhaler. If this is the first time you are using your inhaler, or if you haven't used it in a while, you may need to prime it. Check the instructions for how and when to do this with your inhaler, as they can differ depending on the type of inhaler and medicine. When you're ready to use your inhaler, stand or sit up straight. Breathe in deeply and breathe out completely to empty your lungs. After shaking the inhaler, put the mouthpiece in your mouth and close your lips around it to form a tight seal. As you breathe in through your mouth, press down firmly on the top of your inhaler to release one puff of medicine. Keep breathing in slowly through your mouth for 3 to 5 seconds until your lungs are completely full. It is recommended to hold your breath for approximately 10 counts. Finally, breathe out slowly through your mouth. If your medicine dose requires 2 puffs, you may need to wait before taking the second puff. Follow the instructions that came with your inhaler to know how long to wait between puffs. After using a steroid inhaler, rinse out your mouth with water and spit it out. It's important to keep your inhaler clean so that it works properly. Check your inhaler's instructions for the right way to clean it. Proper use of your metered dose inhaler may help you control the symptoms of your lung condition. If you have questions about the use of your inhaler, talk to your healthcare provider or pharmacist. Ask them to watch you use your inhaler to see if you are using it properly.
This is a real B&H customer. President, fitness instructor and podcast.
All right, so that's how you use a MDI. If you use a DPI, a dry powdered inhaler, the technique is the same. Now, all asthmatic patients will usually be given one of these, a peak flow meter. I think, if my memory serves me right, HES students use these. I think I've seen them out at the field house. But these are very easy to use, and that will help you determine whether or not your peak flow essentially has that really high degree of variability. Okay. So these peak flow meters essentially are made, they're very cheap now. In fact, they have now, so they're digital. And these, often the doctor's office, if you're an asthmatic, they'll give you one of these. And these are used essentially to record your peak flow. You record it. And if you have that high variability, it says you're not getting good enough control with your medicine regime. And then your allergist will review it and essentially say, okay, we need to switch this, switch that, whatever, until you can get under that 30% variability. They're trying to get you at that 20% variability. That's what they want. Okay, we'll finish this on Monday. Make sure you bring your notes in because we'll go over some of the drugs that are on the list here. And after we finish this, we will get into diabetes.